I'll be talking on update of tubercular uveitis in these sessions. TB or not TB is an questions which often remains unanswered and is an enigma. Tubercular uveitis have got varied manifestations, and several investigations can need to be done to identify the tubercular uveitis. TB in India is endemic. 2 million people develop TB every year. Every fourth patient of the TB in the world is an Indian. However, ocular morbidity in patients with active systemic tuberculosis is not that very high. In a study, 1,005 patients in a TB hospital in 1 year, ocular morbidity in active systemic tuberculosis was 1.39%. Most common was healed focal choroiditis. No case of Eales disease was seen. I will be summarizing few of the advances which has been made in the last decade about ocular tuberculosis. We reported in 1995 intraocular tuberculosis, clinicopathological and microbiological correlations, and there is only 5 cases were seen between 1984 to 1994. Subretinal abscess 2 cases, granulomatous uveitis with scleral perforation 1 case, exudative mass in the anterior chamber 1 case, choroidal mass with panuveitis 1 case. And here is an example of a subretinal abscess in a patient with a young lady and who had subretinal abscess, was treated with anti-TB treatment and steroid but did not respond. Ultimately underwent evisceration. Eviscerated tissues, you can see myriads of tubercle bacillus. This is the retinal pigment epithelium, this is the choroid, and this is the subretinal space. Clinical profile of intraocular TB is a great mimicker of various uveitic entities. Can be vision threatening. We reported a case of a rapidly blinding posterior tubercular uveitis. And this is one case where I will show you the example of investigations uses in uveitis. This is a 21-year-old female with granulomatous anterior uveitis with Martin-Put KPs and broad posterior and peripheral anterior synechia. What test we would like to do? We need to do that initial quantiferon TB gold test, Mantoux test, HRCT chest, but ultimately if all are negative, one may need to recourse to anterior chamber tap and subject to molecular biologic study. And in this case, the molecular biologic study was done, and this is a PCR study of the Mycobacterium tuberculosis, MPV64 gene and IS6110, all were positive. And this suggests that the patient is having tubercular uveitis. This is another case of subretinal abscess, and this case's fine needle aspiration biopsy was done, and fine needle aspiration biopsy material showed polygonal chain reaction, Mycobacterium tuberculosis genome amplified. Blood PCR was also positive. What happened to the patient? After treatment with anti-TB treatment based on the molecular biologic study, there is a complete resolution of inflammation. We also published on case of nested PCR positive tubercular amphigenous choroiditis, and this particular patient has got multiple choroidal lesions in the posterior pole, amphigenous choroiditis, and this case has got anterior chamber inflammations. Therefore, we did an anterior chamber tap, and anterior chamber tap showed Mycobacterium tuberculosis genome, my MPV64 was positive. Tubercular choroiditis. This is a patient with tubercular granuloma in a case of spinal TB, heterogeneous hyperintense signals from L1, L2 vertebra with loss of intervening IV disc morphology. And in the fundus, posterior pole is a granuloma lesion was seen, and the patient responded with the anti-TB treatment. Presumed tubercular retinal vasculitis. This is a patient had an extreme retinal vasculitis, fluffy exudates over the retinal vein, and this patient's Mantoux and quantiferon TB gold test was positive, and this particular patient was put on anti-TB treatment with a steroid, and there is a marked resolution of inflammation following the anti-TB treatment with a steroid, suggesting the tubercular etiology in this case. This is a 17-year-old girl, biopsy-proven abdominal TB, and the patient had got what is called frosted branch angiitis with the retinal lesion. And this particular patient was had a tubercular, choroidal lesions in the other eye, suggestive of healed tuberculoma of the choroid. And this is a post-treatment. After anti-TB treatment with the steroids, there is a marked resolution of inflammation, and you can see that all the frustrated branch inflammations has resolved. Eales disease is a form of retinal vasculitis due to tuberculosis. We did a study of polymerase chain reactions of mycobacterium tuberculosis complex DNA from the vitreous sample of the Eales disease, and we found that 5 out of the 12 samples were positive for mycobacterium tuberculosis DNA, indicating the possible tubercular etiology. None of them are, however, culture positive. Eales disease also, we looked in the epiretinal membrane of the Eales disease by polymerase chain reaction, and it showed 47.8% ERM of the Eales disease patients was positive for mycobacterium tuberculosis genome. And this indicates that sequestered mycobacterium tuberculosis genome responsible for Eales disease. And this was supported by further real-time polymerase chain reaction for mycobacterium tuberculosis for so-called Eales disease from the PGI group, and they found 57.8% of the vitreous fluid sample was positive for mycobacterium tuberculosis genome. We wrote in the current concept in the diagnosis of Eales disease and management in Journal of Ophthalmic Inflammation and Infection that the Eales disease should be considered as a tubercular retinal vasculitis based on the current molecular biologic study. There is a study by Dr. Somabha Bosu from Bhubaneswar, LBPI, and they found retinal lesions with exudative mass in the one. They did a retinal biopsy, and the retinal biopsy showed mycobacterium tuberculosis genome positive for PCR. Dr. Vishali Gupta from North India, PGI Chandigarh, they described presumed tubercular serpiginous like choroiditis in patients, and these patients responded with the anti-tubercular treatment. What are the ocular signs predictive of tubercular uveitis? This was done by Dr. Professor Amod Gupta from PGI Chandigarh. They found at least 3 signs which are very pathognomonic of tubercular uveitis. One is a broad-based posterior synechia, retinal vasculitis with or without choroiditis, and serpiginous like choroiditis. Dr. Rimam Bansal has published an article, tubercular serpiginous like choroiditis presenting as multifocal serpiginoid choroiditis, and this patient has got multifocal serpiginoid lesions. We also saw one case with active multifocal serpiginoid choroiditis, and this particular patient had other eye had healed tubercular serpiginous choroiditis, and this case has anterior chamber tap was done as well as anterior chamber inflammation, and aqueous aspirate was positive for IS6110 region, suggestive that multifocal serpiginous like choroiditis can be due to tubercular etiology. Where is the distribution of mycobacterium tuberculosis in tubercular uveitis? This was an elegant study done by Dr. Narsingh Rao group, and they found it's the retinal pigment epithelium, acid fast bacteria get lodged in the retinal pigment epithelium, and they disseminate from there to the other sides. We studied the ocular tuberculosis in 8 patients, and this was published in American Journal of Ophthalmology, and the 15 cases was seen in out of 770 cases, 1.95%, and the varied presentations of the tuberculosis was seen, and this is a choroidal nodule, subconjunctival tuberculosis, panophthalmitis, miliary tubercular choroiditis, subretinal abscess, tuberculoma of the choroid. So results is the choroidal tuberculosis was seen in the 10 cases, subretinal abscess 4 cases, panophthalmitis 1 case, conjunctival mass 1 case. And this is a case where the TB co-infections in the cytomegalovirus lesion. Here is the TB tubercular choroiditis lesions, and here is the cytomegalovirus lesions in the same one patient with HIV infection. We also have a case, or we reported in the tubercular sclerouveitis masquerading as ocular tumor. Here is the mass lesions over here, and this mass lesions, the patient become painful blind eye, and This was enucleated, and the enucleated globe showed a mass lesion suggestive of tumor. But when we did the histopathologic study, we said that there is a chronic granulomatous inflammations, and the mycobacterium tuberculosis genome was positive from the paraffin sections subjected to the polymerase chain reaction. What are the tests to order in case of tubercular uveitis? Mantoux test, quantiferon TB gold test, HRCT test, PCR of the intraocular fluid. Ocular tuberculosis, a clinical pathological and molecular biologic study showed that the 40% positive cases is Mantoux negative. So does indicate that Mantoux negative can also be positive in tubercular uveitis. Quantiferon TB gold test is Dr. Kalpana Babu from Bangalore. They studied and they found the quantiferon TB gold test alone may not be specific for intraocular TB. The significance of this test in a case scenario needs to be interpreted with clinical presentation and other evidences for intraocular TB. Dr. Sudarshan and group from our group published the article on the utility of quantiferon TB gold test in the diagnosis and management of suspected tubercular uveitis. They found it is more useful than the Mantoux test. We also studied that Dr. Shubha Ganesh and our group role of high-resolution computerized tomography of the chest in granulomatous uveitis. We found 81% of the TB and 8.3% sarcoidosis can be detected by HRCT chest. What is the correct duration of antitubercular treatment? This is a debatable issue, but the one study from the Dr. Soon-Fik Chi from Singapore, they showed that the patients with uveitis and latent TB treated with ATT more than 9 months duration had 11-fold reduction in the likelihood of recurrence. So tubercular uveitis is protein manifestations can be vision threatening, diagnostic challenge, systemic examination by internist TB specialist is required. Duration of the treatment is at least 9 months. Now I'll ask one question to the audience. Is it due to TB? This is a case of pigmented hypopia. Do you think it could be due to TB? Unlikely. But you see that, yes, direct smear culture and PCR was positive in this case. Is it due to TB? 50-year-old man had chronic uveitis with pigmented KPs and raised intraocular pressure. Viral. And this is a tubercular viral, this is a viral uveitis. PCR was HSB1 was positive. This is due to TB. This is a 51-year-old lady, gradual dimness of vision, 9 months, diagnosed as tubercular choroiditis in one of the apex center on the country and was treated 6 months with anti-TB treatment. We did a final vascular biopsy and it showed it's a lymphoma. MRI showed CNS lymphoma. Is it due to TB? 60-year-old female, 60-year-old male from Chennai, 618 N10 vision.
Could be, yes.
Could be. Metastasis. Bronchial brush negative for malignant cells, HP suggestive of granulomatous etiology, MRI brain normal, cells elevation of the neurosensory retina. Serum angiotensin converting enzyme was 81 international unit, ESR was 38 millimeter first hour. Mantoux and quantiferon TB gold test was negative. FFA showed initial hyperfluorescence, late hyperfluorescence. Sarcoid TB metastasis has been kept in the diagnosis possibility. Started on oral prednisone 1 milligram per kilogram of the body weight. And you can see that marked resolution of inflammation with the steroid. And these at 3 months, vision became 6/6, lesions flattened. At 1 year, lesions completely flattened, scarred. So this is a sarcoid uveitis. Sarcoid uveitis can present as a multiple choroidal nodule or single choroidal nodule, optic nerve head granuloma or retinal vasculitis. Solitary or multiple choroidal nodule, optic nerve head granuloma, retinal vasculitis, intermediate uveitis, granulomatous or non-granulomatous anterior uveitis. These are various presentations of sarcoid uveitis, choroidal nodule, optic nerve head granuloma, multiple choroidal nodule, retinal vasculitis. What are the tests to be done to distinguish sarcoid and TB? Mantoux, quantiferon, chest X-ray, HRCT chest, bronchoalveolar lavage, biopsy, purified protein derivative, that test, that Mantoux test, etc. CD4, CD8 ratio of the vitreous fluid is highly diagnostic of sarcoidosis. One need to do the ocular imaging, fundus photography, OCT, FFA and USG-B scan. How do you treat sarcoid uveitis? Steroids, periocular, systemic or intravitreal injection, immunomodulators, methotrexate, mycophenolate, azathioprine or cyclosporine. So in conclusion, tubercular uveitis can mimic sarcoid uveitis. Differentiation is necessary. Both have different treatment strategy. Laboratory investigation can differentiate between the two, though at times it is difficult. Thank you.